Hello and welcome to this Health Suppliers segment on Health Professional Radio. Thank you for joining us once again today. Our guest is Dr. Christopher Kearney. He's Regional Director of Palliative Care at MedStar Health in Baltimore. And he's here today to talk with us and give us some advice on advanced care planning for seniors. Welcome to Health Professional Radio, Dr. Kearney.
Thank you.
Senior care planning. What type of care are we talking about? Are we talking about health care, financial care, all of that, or what?
So generally, healthcare would be the concern that we have most prominently in and around our hospital settings. I'm a family doctor, actually, by training, but I've been doing geriatric medicine in the city of Baltimore for about 30 years. So very common issues among our older populations is this decision-making about their health care as their age and as their health progresses. There are options that need to be determined, and best determined well before someone is seriously ill or in the hospital.
So when we're talking advanced care planning, how advanced are we talking about, and does the patient themselves initiate this planning?
Hopefully they would be the ones doing it, and again, in the doctor's office or even at the kitchen table would be the ideal place, not in the intensive care unit or on their way to the operating room in an acute care hospital. The issues have to do with the patient's ability to control their care, and that's one of the things our older patients, or all of us, actually fear, is that somehow we'll lose control of our care as we get more ill. And so this idea of advanced care planning, which actually is not so ancient, it's relatively recent, came up with the Cruzan case, Nancy Cruzan in 1993, young woman who was vegetative. And the Supreme Court in the United States finally said, you have the right to create a document that tells the doctors and your family what you want, even if you can't talk anymore. So this happened across the United States, and this was the beginning of advanced directives. And an advanced directive has two parts to it. The first part is you're asked to appoint someone who would be your spokesperson in any event that you're no longer able to speak for yourself. That could be a spouse or obviously an adult child, or it could be anyone that you trust. The idea is that they will know your wishes, and if such time comes, they will not be making decisions about your life, but they will only be reflecting the decisions you told them you wanted. Okay. So that person would be carrying out your wishes, and that's a great idea, and it has worked very well in over the years, although it's not, of course, universal because many people don't get around to creating that document. The second part of the advanced directive used to be called a living will, and that was a part of the document where you could spell out in detail if you get in certain circumstances you would want this done. If you got into another condition, maybe you would want something else done. And that's also a useful document, but it's very hard for us to predict the future exactly. So that's why the combination of both the instructions or living will and the healthcare agent, we now call it, or power of attorney for healthcare, is what is the ideal arrangement.
And when you say power of attorney, we get pictures of legality. These documents and these directives that you're talking about, they are always upheld legally. Is that correct? Or how many challenges can a person bring? And can those challenges?
That's correct. They're legal. They are legal documents. The term power of attorney we moved away from because it was confusing, because there's a power of attorney for financial dealings as well. So for healthcare, the term healthcare agent was substituted in many areas. Sometimes they call it the surrogate decision maker, but it is a legal document, and it, in most places, I believe practically all places now, it is a document that can be created literally at the kitchen table. It does not need to be notarized. It doesn't need to be done with an attorney or with a court, a document. And so once it's been, and then the only legal requirement generally is that two adults have witnessed the document, and they say that you were in your right mind when you completed the document. And once that's done, that's a legal document and would be recognized across state lines, generally across the United States.
Healthcare implies financial cost and responsibility. Should the person who's executing these documents from a healthcare standpoint also, I guess, coordinate with whomever is going to be handling the patient's finances to make sure that those healthcare directives are financed properly?
Yes, that's a very good question. You're getting into a tricky realm where, in general, in our world, we try to keep these things separate, although we know they are not separate. Most healthcare decision-making in the United States is actually not, honestly, financially based. When you get into extreme treatment modalities, transplants, and exotic treatments, finances do come into the picture. Okay. But generally, for the routine care that I've seen over the last 30 years for seriously ill patients, older patients in the hospital, the actual insurance, the payment for care is usually not the issue. The issue more commonly gets to be the value of the treatment itself. Okay. As the patient gets further along, what will the next trip to the hospital mean? What would the next surgery mean? What about putting a feeding tube in someone who may have stopped eating naturally, which all our Alzheimer's or demented patients eventually get there? What about chemotherapy or the next round of chemotherapy? What about care in the ICU, being put on a ventilator, being on a breathing machine? Those kind of things all get to be very important issues for the seriously ill. All of them have great benefit in some cases. In other cases, they prove to be more suffering than anything else.
In your experience, talk about how to get the conversation started with the patient if they're maybe a little bit reluctant and have been extremely independent their entire life, basically taking care of everybody in their family, and now all of a sudden the tables have turned. How do you get that conversation started, especially, if you're the kid or the grandchild of the patient?
I think generally this isn't everybody's favorite topic, although in my experience, again, particularly as people get older, they tend to be much more realistic and they know something's coming. So they do have distinct ideas about this. And you're right, there has to be permission. Someone has to say this is okay to talk about this kind of thing. So it wouldn't be uncommon for me to say, well, for an example, if you're out shopping at the giant supermarket, tomorrow afternoon, and you fall out in the parking lot, you will find yourself in a hospital somewhere. And if you are no longer able to communicate or tell people what you want, the doctors, everybody's going to be wondering, what are we doing? What is the right thing to do? What would this person want in terms of their care? So I say it that you're doing a favor to your family if you at least take time to sit down with them and appoint someone to be the healthcare agent or to be your spokesperson. It clears the air for everyone. It lets the doctors know who to talk to. And the gift that I still think is the gift is if you tell your family members what you actually would want, they're not on the hook. They're not having to make a very difficult decision about someone else's life. They're just carrying out your wishes. So in some ways, it's a gift to your family to do it.
At there at MedStar Health, do you engage in any type of pre-discussion counseling for, say, the adult children of the patient? If maybe the patient is in the throes of Alzheimer's, or maybe they're getting there. Is there counseling that you offer, either as the physician who specializes in this type of thing, or MedStar as a whole, for getting that conversation started?
Well, I'm not sure, even though I'm a MedStar person, that I can claim we do it any better than anyone else. I think you're exactly right in what you're saying we should be doing. I think in general this is an outpatient, or it's a primary care activity is where this should be happening. I think it is done much more than it had been in the past. I think the availability of the advanced directives, in Maryland and in a number of other states, there's another instrument available now that is called, I'll say the name, in Maryland it's called MOLST, M-O-L-S-T, and it stands for Medical Orders for Life-Sustaining Treatment. Now this thing is an instrument that was originally used in California. It's probably roughly 20 states in the United States. This is slightly different than the advance directive that I was referring to, or the appointment of a healthcare agent, because this is actually a doctor's order. It's a legal order that's written that would be adhered to, would be respected no matter where the patient was. So it details even more closely the kind of things I'm talking about, and it's usually reserved for the patient who is closer to these serious problems. Maybe a person who's been in a nursing home, maybe a person who's getting frailer, who really may be facing these serious life-ending decisions. This document with the doctor and with the family, you can actually put orders into the medical record that says I want this or I don't want that. So it's even a stronger a document of what the patient's wishes are. It can be altered, of course, but once it's done, for instance, it's honored even if a patient is at home or if a person is in an ambulance or if we did it in MedStar and the person wound up at Johns Hopkins or the University of Maryland, the document that's been created would be respected as a legal order, doctor's order in the state of Maryland or whatever state you're in. So that's called MOLST, or in some states, POLST, for physician orders.
Okay.
So that's another modality that you might hear about or people could be aware of.
If a patient who has been coming to see a physician for many years, but for whatever reason, they don't have any family, is the physician, their general practitioner, in a position to be the person that is going to carry out these directives for that person, even if that person is at another facility in another state? Can that facility or that state call on this doctor to be, for lack of a better term, that person's next of kin?
That's right. That would be a little bit unusual for the doctor actually to act in that role. They usually discourage that, but there are you're pointing to a common issue where what I've described sounds very good and very useful, and it is when it's done right. Many patients still arrive in hospital without these documents, without advance plan documents, certainly without these MOLST forms. And family, it can be quite a variety of things now, as we all know. Many people arrive without immediate family and without someone knowing exactly what their wishes are. So the medical teams, the doctors, these hospitals are very often in the thick of trying to make good ethical decisions about what is the right thing to do that would still be beneficial but not going too far and continuing suffering. So, but it can be complicated. For instance, a doctor, myself, I can certify in the hospital that something is medically ineffective to do, that we won't do it because it won't work. And if I have a second doctor agree with me, then we are essentially protected by law, and that is in the state of Maryland, but many other states have something like this. Okay. So doctors can and do, when they have to, say, okay, I'm going to make the decision and certify that I think this is the right care, and doing something else would be the wrong care or would be too far. So we do that in not unusual, not rare circumstance. Every hospital does that.
Where can our listeners go online and get more information about MedStar Health and advanced care planning for seniors?
Well, MedStar Health has a very extensive website that you would find many of these questions answered in better detail than I just did. But I think in the state of Maryland, where we are, the Attorney General has very good information, but this would be true, I think, in practically any state. If you Googled basically advanced directives, you would be overwhelmed with information on many of these subtleties, the things I'm talking about. The actual forms are available. Every state creates them. 5 Wishes is a good document that many people are aware of that goes into some very good detail about how to make these decisions for the family, for the patient at home. So those would be places I would look.
It's been a pleasure, Doctor.
Thank you. I enjoyed, talking about a topic I like to talk about.
Great. You've been listening to Health Professional Radio. I'm your host, Neal Howard, here on this Health Suppliers segment. Been talking with Dr. Christopher Kearney, Regional Director of Palliative Care at MedStar Health in Baltimore. Transcripts and audio of this program are available at healthprofessionalradio.com.au and also at hpr.fm. And you can subscribe to this podcast on iTunes and listen in on SoundCloud.